Hi, this is Julie Lubinsky. I am Associate Director of Digital for the Christopher Dana Reeve Foundation, and I'd like to welcome you all to this month's edition of our live chat with Nurse Linda. Linda is a leader and provider of rehabilitation nursing for over 40 years, most recently developing activity-based rehabilitation strategies. She is also the writer of our interactive Ask a Nurse blog on our online paralysis community. And she is on Wednesday evenings answering your direct questions on our online community. So please be sure to register for that. And every month we are lucky enough to have a live chat with her. So now I'd like to turn it over to Linda. Hi, Linda.
Hi, Julie, and thank you. And it's so nice to be here today. I had the lucky opportunity to talk to some people over the last week who are people who listen to the webinars and read the blogs. And it's always such an exciting time for me to talk to people because I'm always writing or talking to you, but I hardly get to meet people. Although I will be at the Abilities Expo in Houston on August 3rd. It's a Saturday of the first Saturday of the month. So I hope to meet a lot of you there. I'm very much looking forward to that. That's always a lot of fun for me to meet people and to talk with you. Today I wanted to open the program talking about a couple of blogs that I've recently written, and then we'll get to your questions. But over the last couple of weeks I've written some blogs about testing that sometimes has to be done when you have a spinal cord injury. The first one was the dreaded colonoscopy, which plagues us all. Traditionally, it's been said when you're 50, you need to get your first colonoscopy. Now the American Cancer Association says at age 45, you should be getting your first colonoscopy. Unfortunately, when you have a spinal cord injury or paralysis, it does not exempt you from other diseases. And so colon cancer is like the number 4 cancer, and so it's very important to have that checked out. The good thing about your colon is that if you have a colonoscopy and you have a small little blip, a polyp, or something in your bowel, they can detect that in the colonoscopy, and if it's small, they can usually remove it, and it either eliminates, if it had started to become cancerous, it can take care of it right there at that moment, or you can have polyps or other kinds of little things that might pop up in your bowel immediately removed that never even become cancerous. So, that's really quite a wonderful thing. But, of course, people don't want the colonoscopy because they're going to go in an area where, the sun doesn't shine and you don't usually show off that part of your anatomy to other people. So oftentimes people are a little embarrassed about the colonoscopy. But nowadays it's really nothing to be embarrassed about. You go in, you have the colonoscopy done. You're usually given some kind of light anesthesia. You do not have to be placed on the ventilator, but you're really kind of sleeping through the whole thing. So you have a colonoscopy, you wake up, you don't even know what's been done to you. It's kind of a marvelous system that they've worked out in that way. And then if they find something little, as I said, it's just taken care of, it's gone. If they do find something, they will ask you to come back in 5 years. If they find your bowel to be clean, you don't have to go back again for 10 years. So those colon cancers are sometimes slow growing. Sometimes they can be pretty quick. But for the general population, like you and me, spinal cord injury or not, a colonoscopy is a pretty nice thing to have done to protect you from any future problems down the road. Now, the thing that people really do not care about the colonoscopy is not the procedure so much, but it's the dreaded prep. And it's dreaded by everyone, no matter who you are. The substance that you drink tastes icky. It causes extreme quick movement of your bowels that evacuate with such rapidness that it's kind of always surprising. And it continues on for a great length of time. They have to get the bowel completely cleaned out because if there's stool in there, then you can't see the bowel wall, so you don't know, you might be missing some polyps or something that might be there because stool's covering it up. So they have a complete flush out of the bowel. It's not a kind of prep that you have. It's not a bowel program type of prep. That empties the lower bowel. In your bowel program, you want your bowel to work in a normal fashion because your bowel is regulated by the autonomic nervous system, so that means it automatically works whether you have a spinal cord injury or not. After a spinal cord injury, it can slow down terrifically, which may make it feel like it's not working, but it is working. And so there are different things you can do with adding roughage to your diet, maybe taking some roughage supplements to get that bowel moving. If you drink a warm beverage like a cup of coffee, or if you have just even drink a cup of warm water, or eat a little something about 20 minutes before your bowel program that gets your bowel stimulated to working. So there's all kinds of things you can do to help that along. But in the colonoscopy prep, they clean the bowel from top to bottom, from stem to stern, as they say. So sometimes you have to drink several bottles or maybe even a large bottle divided up of different preparations. Every person, every gastroenterologist that does colonoscopies has a different procedure, so they're all a little bit different. But it usually involves drinking some kind of fluid that tastes icky. There's some electrolytes in there that are flushing out the bowel, and so that's that icky taste that you taste. Most people will say if they refrigerate the fluid, it doesn't taste so bad. I've also heard, and I've done this myself, where if you have to take the fluid, if you drink it through a straw and you carefully place the straw kind of back further in your mouth, then that fluid doesn't hit your tongue where all your taste buds are, so you don't taste it as much. And so that seems to help. So there are different things you can do when you have to drink the fluid. Now there are other things, though, coming out the other end. All of a sudden your bowel is working, and it's working quickly, and it's a problem getting to the toilet. You might not recognize when the bowel's reacting. So this is something you want to take a great deal of care with because you don't want to have accidents or have that stool, which is from higher up in your bowel, so it's very, very acidic and kind of burns your skin a little bit as it's coming out so quickly. So some things that you can do is to put some protectant on your skin. Some things is some of the big heavy-duty skin lotions like diaper rash preparations that have that zinc oxide kind of real thick stuff that you just can't scrub off no matter what you're doing. That protects your skin so that that rough stool gets on that protectant and not on your skin. Some people will tough it out and spend a lot of time on the toilet just waiting, which is not necessarily so good for the other parts of your skin because then you're on that toilet seat not properly cushioned, so you could have skin breakdown from just sitting there for so long. And, of course, when you're sitting on a seat like that, you have a much higher chance of developing a hemorrhoid or multiple hemorrhoids. So we don't want that to happen either. So if you can rest in your chair in between, but if you don't know when those periods of stool evacuation are going to come, there is a little disposable piece of equipment that you can buy. It's called a rectal bag. It has an adhesive that fits just around the rectal opening, and so then this sharp proliferation of stool that's being evacuated collects in a bag and not on your skin. Now, you don't want to wear these all the time because if you keep that rectal area sealed up with the plastic bag, it's not getting the air that our skin needs just to maintain itself. So it's not a full-time thing that you might want to use, but in this particular case for a one-time shot, you might want to try to use it. Now, the rectal bags are rather small. They would hold a normal size bowel movement, but they will not hold the amount of fluid that will be coming after the preparation for colonoscopy. So sometimes people will put a little slit in the far end and attach a separate bag to the rectal bag. Now we're talking about a real feat of engineering here to get that all safely sealed up, and then you can just dispose of that. There are different insurance and payers that because of the prep, if you have a spinal cord injury, they will allow an admission to the hospital the night before so that you can have help with doing the prep, help with getting cleaned up. It's a very nice process. It's not really advertised. So you'll have to contact your case manager and ask if this is possible, or have the doctor petition for your insurance for this on your behalf. So people are going more and more that direction with colonoscopies for people with spinal cord injury. It might not be your desire to spend the evening in the hospital and having all this done, but if you weigh your options for certain individuals, if you live alone or if you don't have much help, or this is going to go on into the night, sometimes it's a welcome treat to have that all taken care of for you. So there are options. You might also talk with your healthcare professional that's going to be doing the test. Sometimes people, the provider will allow a colonic type of enema. Again, it's not something you want to be doing all the time because you want your bowels to be working in their normal way. But sometimes people will go, they'll have a colonic, it's done one time, and then it's over and it's finished for the day. Now, some providers are not that familiar with these and they don't allow them, or there might be something unusual about your case that would preclude it. But then again, it's always just something you can ask, and if they say no, well, okay, you're back to the usual way. But those are two options that might be possibilities. Another thing that you want to be very careful about is autonomic dysreflexia, because having all that fluid leaving your rectum so quickly can stimulate a dysreflexic attack. When the procedure is being done and you're asleep, so you might not be able to tell the person doing the procedure, I'm starting to get a headache or a stuffy nose. So if you recognize the symptoms of autonomic dysreflexia, you'd be asleep and you might not be able to communicate that to someone. So be sure that your provider knows if you have autonomic dysreflexia, or even if you've never had it, that it's a potential for you. You are being monitored during the procedure, but as we know, people who have spinal cord injury, their blood pressures tend to run particularly low. So if you're having the procedure and your blood pressure might go up to 120/80, which is for the general population a normal blood pressure, but for you, that might be in the range of autonomic dysreflexia. So be sure you tell your provider what your normal blood pressure is so they can be alerted to that during the procedure. It's just an extra band of safety. Now, after the procedure, you can go back home. Then you want to resume your bowel program to keep in that same pattern that you were in before, because you're trying to train your bowel to regulate. So you want to be sure to pick up with your bowel program where you left off. The other procedure that I had talked about this past week was urodynamic testing, and this was a result from somebody in the blog that had written in, and they had gone for urodynamic testing, and it didn't turn out to be such a good experience. And I'm really sorry that that happened, but these are the kind of things that we need to be prepared for when people go for these kind of testing. So urodynamic testing is an assessment of the lower urinary tract. It's assessment of the bladder and the sphincters that let urine out of your bladder. So after spinal cord injury, you know that you're doing intermittent catheterization, or you're having some other way to remove urine from your body, and this is a test of that lower tract to see what the pressures are. Now, you might want to have one, or you might even have one right after your injury or sometime shortly thereafter, and that will give your healthcare provider a baseline of where you stand, what your pressures are in your bladder, how your sphincter works in coordination with your bladder. Because if that isn't all working together, the pressure in your bladder can build up. urine might not be able to be released if the sphincter is clamped closed when the bladder's trying to contract to eliminate the urine. And what will happen is the urine backs up the ureters into the kidneys. The kidneys have no method of storing urine. They create urine, but it immediately goes down the ureters into the bladder where it's actually stored until the appropriate time to eliminate it. So the kidneys don't have any capability. So if the pressure gets too high in the bladder, the urine backs up into the kidneys, and that causes kidney damage. It's very important to have this test done. It's usually done one time a year. Now, your healthcare provider might find something and say, we better go ahead and do one early. Or they might say, well, things are going really great. Maybe we can wait a month or two. But the benchmark is to have the procedure done every year. You might even be in an area where maybe you've never even had a urodynamic test done. So it's something you might want to talk to your healthcare professional just to make sure that everything's working in coordination and that you're not having any problems, because you don't want to damage your kidneys, then they're just gone. And so it's very important to maintain this part of your health. Now, in this procedure, they will call you into the office, and if you are going to a person who does urodynamic testing with individuals with spinal cord injury, they'll be very aware of what your special needs are for your skin care, for catheterization. They'll be monitoring for autonomic dysreflexia, because here again, you're going to have your bladder filled very quickly, and that is one of the hallmark triggers for autonomic dysreflexia. So if the person is familiar with that, just tell them your special concerns. If they're not familiar with that, you're going to have to work with them a little bit more to let them know you do have problems with autonomic dysreflexia, or it could be a potential problem for you. Again, here's my normal blood pressure, so they're aware of that. If you're going to a person that doesn't often do these procedures, urodynamics is done with a lot of people, a lot of times with women. Sometimes there's damage after pregnancy. Sometimes men with prostate troubles might have urodynamic testing. So there's a lot of reasons why people have this testing done. Some providers just do not see a lot of people with spinal cord injury. So be sure you talk with the person that you're scheduling your procedure, and make sure that they know that you cannot be on the table, which is a cushion table, but it's not cushioned to the type of medical grade cushioning that you have in your wheelchair. So it's a little bit, it doesn't disperse your pressure as well as your wheelchair cushion will. And so let them know that you cannot wait on the table an hour for the provider to come, that you need to get on and get off as quickly as the procedure can be done. It usually takes about an hour to do the whole procedure. So you're put on a table, you're put in the gynecological position, so females are well familiar with this. Males, it comes to as quite a surprise, because they are usually not positioned with their legs bent up and their legs spread apart. And so this kind of comes as a surprise to men. Women, although they've probably experienced this position before, are really not comfortable with it. And generally people are kind of not comfortable with this whole procedure because you're so exposed, and at different points in the procedure you're asked to try to empty your bladder, which emptying your bladder in front of, a person doing the test and maybe another nurse in the room, it can be kind of an embarrassing procedure. But your modesty is protected as much as possible. It's really an important test, and think, well, I'll never see these people again outside of this room. So, you just go on through it. They'll empty your bladder, make sure it's all empty, and then they'll put in a special catheter that has some sensors in it. So there'll be pressure. The pressure in your bladder is being measured. The pressure in your sphincter is being measured. There probably will be another probe that they will insert into the rectum, because that's going to measure the pressure in your entire abdomen. And then they put some electrodes around the area to measure what your electrical production in your body is. Now, they don't put electricity into your body the way they do with a nerve conduction study, so it is not painful, but they will measure what your own production is of your nerve function is. So you have a lot of electrodes and tubes and things that are attached to you. Then they will put some fluid into your bladder, and they'll fill your bladder rather quickly. It's slowly, but it's quicker than what your bladder would normally fill if you were just living your life. And then they measure the pressures, and they see how you're coordinated with your sphincter in your bladders, the pressure in your abdomen. So you can see that this might trigger an autonomic dysreflexia response. So you want to be sure you're awake for this procedure. You want to be sure and let them know. If it comes time for you to do a pressure release, tell them that you need to be doing one. There are different points in the test where they will ask you to do the Valsalva maneuver, which is to apply pressure in your abdomen. So you can do a pressure release at that time because it will imitate a Valsalva maneuver. So you can work in your needs in the middle of this test. But you need to talk to the healthcare provider to let them know that this is going on, so they can be like, okay, get ready, and now we're going to do this. And so you, instead of Valsalva, do a pressure release, and then it all pulls together. So hopefully you'll be able to get that testing done and get that baseline, and then you'll be able to see as time goes by if you have any changes. And so if you detect changes early enough, you can prevent any kind of problems with your kidneys. So both very important tests that need to be completed. The colonoscopy every 10 years unless they find a little polyp or something, then they'll have you come back every 5. And the urodynamic testing should be done as soon as possible after you have your spinal cord injury. The colonoscopy starts at 45, and the urodynamics testing should be done close to some time when it's safe and you're able to perform the test after your injury. So it usually comes either right before you leave the rehab hospital or shortly after that time. So very important things. If at any time anybody has experienced, like we had this one gentleman that stimulated the whole urodynamics blog, I had another lady who stimulated the initiation of the whole colonoscopy blog. So anytime, if you have any thoughts or you have any experiences you want to talk about, you can write them into the blog or ask at the webinar, and we'll be happy to discuss those things, because if you had that experience, you can guarantee that other people have had it as well, so they'll admire you for speaking up on their behalf. So please feel free to go ahead and do that. So we have some questions in the blog today, and there's some really good questions I think that will be of interest to a lot of people. And the first question is, what can be done about nerve pain that manifests as cold feeling in the arms and legs? And this person is a C4-5 spinal cord injury. So first of all, the fact that there is this feeling of coldness in the arms and legs, if the person's feeling that, that's good. That means there's some sensory connections there. And so when the spinal cord injury leveling is done, the assessment of where your level is and the completeness of your injury, you've all been through that test with the light touch and the pinpricks and moving of all the joints, and can you move it this way, and can you move your arm that way, and they go through every single segment of the spinal cord nervous system. And so the way that people are graded is by the last normal level of the spinal cord injury. The last normal functioning is where you get graded. That becomes your injury level. So some people have what they call a zone of partial preservation further down, where they have maybe some sensation, some movement, but it's not what is considered normal kind of movement. It's affected in some way. So some people have a level of injury at one place, but they actually have a little more function than that. And that's what we try to harness and capture in rehabilitation, is to harness those different levels of injury and really exploit that area into functional gain. And so this person is feeling cold. Now, when I first read this question, I thought they're feeling the cold, which meant that their body was feeling it. And so I thought, well, that's good. They have some sensation that's getting through, and so that's a great connection to know. That's good information, and you can harness that and use it for other things with therapy. However, now I'm wondering, as I think about it, maybe just their body feels cold. So remember that when you go out, this sounds, I know, rather simple, but a lot of people, I see people like this all the time, they go out and they say, well, I don't have any, it's snowing outside, it's really cold. And they say, well, I don't have any feeling in my feet, I don't feel the cold, so I don't need to wear shoes and socks. And they'll be sitting there barefoot, like at a football game or something, with the snow falling on their toes. And I think, oh my goodness. I say, oh, I don't feel it, so it doesn't matter. But your body will still react to it. You can still get frostbite. You can still get complications. Even though you may not feel it, your body's still reacting to the cold below the level of the spinal cord injury. And so, your brain's not perceiving it, but your body's still reacting. And that's when you get those abnormal sensations that turn into autonomic dysreflexia. So if it's cold outside, dress for the weather. If it's warm outside, undress for the weather, I guess, but dress appropriately for the weather. If it's rainy, be sure and wear some kind of protective clothing so you're not sitting in wet clothes all day or even damp clothes. So all those kind of things. But if you're feeling that, if the extremities feel cold, then they probably need a little blanket. Maybe if you're sitting in the air conditioning, you might need just a sheet over your body to keep your temperature regulated. On the other hand, if you're feeling that cold, that's a really good thing. It might feel bad because you feel cold, and that makes people feel not so good. But it's a good thing because you've got some connections that are being made in your arms and legs. So that's an important piece of information that you will want to share with your healthcare provider so that they can provide some therapy and hopefully capture that sensation so that you can maybe feel like if a cloth is underneath you or if something's too tight or if something's rubbing you. So all those kind of things, are actually a good kind of thing. Now, talking about nerve pain, and that's what the question is all about. So nerve pain is one of the hardest things to treat because it's different for everybody. So two people can be sitting there and they say, I have pain. One person would say, well, my pain is on a scale of 1 to 10, my pain's a 2, and the other person can say it's a 10. You can have, I'll just pick something like, say you have an injection in your arm and you have feeling in your arm, and one person would say, oh, that injection, the pain was a 10, and the other person says, no, the pain wasn't so bad, and it went away quickly. I'm really, not bothered by it. So people's perceptions of pain really dictate how pain is treated, because when somebody says they have pain, then they truly have pain. Excuse me. So the way pain is treated is usually started out with some sort of oral medication. Pardon me. And so the person's given, there's a variety of different medications that can be provided. There are medications that treat nerve pain. They're gabapentin and the pregabalins. They're known by the trade names of Lyrica and Neurontin. These are the only two medications that treat nerve pain. Sometimes people are given opioids. We all know about the opioid epidemic. Sometimes people are given other kind of analgesics for their pain. They don't really treat nerve pain. They treat muscular ache pain, or they change the way our body perceives pain, but they don't really affect the pain. There are some other medications that will help with pain, and these are anti-seizure medications and antidepressant medications. Now, some people say, I don't have depression, I don't need depression medication, or I don't have seizures, I don't have that medication. But both of those are not given in the strength that would treat a seizure or in the strength that would treat depression. They're given at a much, much smaller dose. So what happened with people who took anti-seizure medication and antidepressant medication was one of the side effects of those medications was they found that it also helped their nerve pain. So it was just an anecdotal thing that people found out, people that took those medications because they needed them, and then they said, well, they recognized this, and so they switched and started making these medications in a much, much lower dose. And so people take those for nerve pain, and those will work for some people. Now, when you take an oral medication, that medication goes throughout your whole body. So sometimes people on these nerve pains will feel really tired, and they want to sleep all the time, and they're just real lethargic. They feel like they just can't get up and wake up and get going. That feeling wears off over time. The medication you reach a tolerance to it over time, and these medications have to be increased and increased. Sometimes people will take combinations of these medications. So if you have nerve pain, that is usually the first step. Now, ironically, what people tend to overlook, because it's not a prescribed thing, but sometimes people have pain, so they don't want to move. But when you have pain, if you have some very gentle movement, sometimes that will help relieve the pain. And so if you do some very gentle range of motion, sometimes that will help reduce the pain. If you think about people who have arthritis, it's a different mechanism than nerve pain. But if you think about people who have arthritis, they don't want to move because it hurts to move their joints. But if they very gently do range of motion, their joints become more supple, and that reduces their pain over time. It's the same kind of thing with nerve pain. Now, your nerve pain might be such to the point that range of motion isn't really helping that much, but it's a good adjunct to either starting out with trying to move or having somebody move your joints for you. That is a good starting point, and then maybe adding medication if that's not working, or if you're on medication, don't forget to be moving your body, and that will help ease the pain because you're stretching those nerves and you're providing input to those nerves that want to be working. And so even though the person's not moving their body themselves, somebody's moving their body, and so that helps relax those nerves a bit. Now, further on, there will be some injections that can be given in the area of the pain to help dull that pain. And then in really extreme cases, there are some surgeries that can be done, but that's like really extreme. So I'm not going to get into all of those because I'm hoping nobody will need that. But sometimes if you've been taking some nerve pain pain medication for a while and you find it's not working and you need to up it, sometimes people just get a tolerance to a particular kind of drug. So sometimes you need to change to one of the other drugs for a while and kind of go back and forth. Treating pain is very much a trial and error kind of situation. So your healthcare professional has a good idea of making an assessment of what you need. They have a good idea of knowing what drugs usually treat what you need. But when you get right down into the specifics, you have to work with them. It takes about 6 weeks for nerve pain to be affected by a particular drug. So sometimes I've been taking this medicine for a day or a week, it's not helping. No, it's not going to help for about 6 weeks, so it's very frustrating. So if you can add movement, sometimes people will add just a warm cloth. Now, you never want to use a heating pad or a cooling blanket because that will burn your skin. But if you just use like a warm washcloth in that particular area where the pain seems to be generated, then sometimes that helps, sometimes moving. So that's usually the way it's kind of in a hierarchy how pain is treated. You start out with the lowest, and then you keep working up until you finally reach some kind of treatment for the pain. So sometimes people have resolution of the pain, sometimes people continue on with maybe pain not as bad as they originally had. So there's just but they have some pain, but they learn to live with it. It's all very much a trial and error, and it's unique to every single individual. So it's very frustrating for the patient. It can be frustrating for the care provider as well because they want to help you and they're not seeming to hit on the right thing. So that's generally the way that pain is treated. So that's just, for whichever direction you're going with that problem. The next question is a person that's having a hard time finding male external catheters that will stay on. Yes, I know all about this. This can really drive you nuts. It says, can you recommend a brand? Well, this is an interesting thing because there are so many different shapes and nuances to the male penis that it's hard to recommend one brand because different brands work better for different people. Now, usually what the problem is that sometimes people, men, because men wear external catheters, women do not have the anatomy for an external catheter, although many are developed, and there's a lot of new products on the market right now, so we have to see how those turn out. But historically, this is a male problem. If somebody voids in, if they don't just dribble or leak all the time, if there's just a small trickle of urine coming out all the time, usually the external catheters can accommodate that. But males whose bladders contract and they have a big spurt of urine often have this problem with the catheter staying on because the force of the urine blows the catheter right off, and then you're left with wet pants, and that can be really embarrassing in a social situation. So what kind of catheter works? There's all different kinds of brands, and there's different types. Now, I will give you this tip that many of the catheter supply companies will send you out what they call a starter kit or a sampler kit, and we'll have a variety of, several of the same kind, but different kinds. So there are some kinds that work for some people, and then there are kinds that work for other people. There's the kind that you can put the catheter on where the adhesive is in the lining of the external catheter. So the whole catheter is stuck to the outside shaft of the penis. Now that adds a lot of ability to stay on because the entire shaft of the penis has the sticky stuff of the external catheter attached to it. So that's a lot of surface area covered. Now, those can still blow off in a major output of urine. The other kind of catheters are the kinds that have some kind of elastic tape that holds the catheter on. And I say elastic tape because of changes in the body just during the day through normal living. If you have a spinal cord injury, if you have paralysis or not, your penis tends to fill with fluid and then it empties of fluid just as an anatomical response. So you might not feel yourself have a full erection. You might have an erection, or you might have some erectile properties that you can't even see, but your penis is changing sizes and diameter throughout the day. So you have to have elastic tape that can stretch and accommodate this and contract back when needed. So elastic tape is the key. Now, there are some that will have external catheters that you put the external catheter on the penis, and then you put the elastic tape around the shaft of the penis, either in a spiral form, or if it's elastic, you put it on so that it's held and pinch the two ends of the tape together so that the elastic can still extract and expand and contract, not so that it's held rigidly on there, because you have to have that particular feature to this. So there's all different kinds of brands that come that way. Now, generally what happens is when you have that big expulsion of urine that automatically comes out, the catheter may come down to the head of the penis. If you're circumcised, the head of the penis may hold that catheter on, and some people, manage with that quite well. If you're not circumcised, the catheter could still fly right off, with the tape on the outside of the catheter. So a good thing to do is to contact whoever is supplying your catheter, ask them if they have an external catheter sampler kit. Some of the larger companies will have these if your particular company doesn't, and they'll give you a variety of all different kinds of brands and all different kinds of ways of holding that catheter on. So get one of those and then experiment and try with the different ones to see which one works for you. That would be the best thing. I recommend a brand. Well, there are different brands work for different people, just depending on what their situation is. So the best thing to do is to get that sampler kit. They're free. And then the idea is that then you will buy your external catheters from the person that sent you the sampler kit. But, you don't sign a lifelong contract to that. So get the sampler kit and try those, and then you'll see which one works for you. Hollister makes them. Bard makes them. There's a company down in Florida that I really love. It's a smaller company, and their name's escaping me right at this minute. I'll have to think of it. And I'll think of it when I'm not thinking about it, you know what I mean? And so, but they do an excellent job with providing these sampler kits. Okay, where can I find out more information about C3 Asia D recovery rates, specific healthcare specialists and treatment centers? Well, a great place to call is the Christopher and Dana Reeve Paralysis Center. And they have a resource center there, Paralysis Resource Center, and there are people there that will talk to you on the phone, and they'll tell you about locations that are close to your area. The two big centers are Shepherd Center in Atlanta on the East Coast, and Craig in Denver on the West Coast, but there are many other wonderfully advanced facilities around. In Texas there's Baylor, there's RIC in Chicago. So there's a lot of places that treat individuals with spinal cord injury. Now, you can go to your local hospital, and if they have a rehab center, they would probably provide rehab for people with spinal cord injury, but maybe they don't see a lot of people with spinal cord injury, so they might not have some of the advanced equipment, or they might not be aware of some of the advanced treatments, although many of these local facilities have contacts to these major centers, and they will work with them to find out what would work best for you. So if you want to call the Christopher and Dana Reeve Paralysis Resource Center, they will be able to give you names of places. They'll give you several options. They don't recommend any particular place, but they give you options in your area. Or if you want to go to some place that has this specialty in spinal cord injury, they would be able to provide you with information about those particular places. So recovery rates, Asia D, so good, because that's an injury. Some people, the recovery rates are really depend a lot on the injury and the type of injury and what kind of therapy that you're getting. But this kind of ties in to the next question. With almost 6 months ago, since my accident, they've got an incomplete SCI, and how would I go with my recovery and how fast should I go? So I don't know if you're the same person that wrote in or if these are two separate people, but both of you have an incomplete injury, so you want to go, if you can, get to a spinal cord injury specialty center and then get as much therapy as you possibly can. If you can get the advanced therapies, that would be very helpful. Things like aquatic therapy and You might not be able to tolerate the electrical stimulation, but if you can, the partial weight supported walking, all different kinds of things to retrain your body, re-educate your body for recovery. So both of you should get some spinal cord injury specialty, and then go as fast as your body can tolerate doing it. That seems to help, I think. The more therapy you get earlier on, it seems to be helpful, but that is not to say that people who've been injured for a long time don't benefit, because you benefit as well. And so there's still a lot of experimentation on what should be done and how much should be done. And but if you go to a spinal cord injury specialty area, they'll be able to provide the treatment that would be most beneficial to you. Next question is a very significant question here. This person writes in that my son has had a hip bone infection. Amputation is next. Is there an alternative? Well, of course, I don't know the situation, but I'll just talk in general terms. Sometimes when the bone has an infection has invaded the bone, it can be very difficult to clear up. IV antibiotics are used if the wound is closed. If the wound is open, you can use IV antibiotics, and you can also use local treatments, so putting different treatments into the wound if it's open. If it's not open, you want to leave it closed. So in this particular case, amputation is next. I'm just going to speak very, very generally. As I said, I don't know anything about this case, but be very leery of this. If the bone is so infected that the infection, once it's in the bone, it can travel throughout the body very easily, through the bone marrow and the blood system. So it might be that might be the best alternative. I will also caution you that sometimes there are practitioners out there that will say, oh, this person has a spinal cord injury. They're not using their leg. They maybe have not been enlightened about the advances in treatment recovery that are coming. And so their philosophy in the past has been, well, remove the leg because they don't need it, and it will make transferring easier for the person who has to lift them, because they won't have to lift the weight of that leg. That is not the way that people think nowadays. So that's why I say just be leery of those kinds of things. Always get a second opinion. Clearly it sounds like amputation is not the direction that you're wanting to head. Sometimes wound specialists can clear up the infection. It takes a long time, but sometimes that can happen. Sometimes maybe if the hip bone is infected, they can do a replacement as opposed to a full amputation, because I'm assuming that the rest of the leg is fine. If the infection's not in the bone down the leg, maybe some kind of hip replacement might be a good alternative. I will say, with that in mind, it is very difficult to operate on infected bone, because that has a tendency to open up the area to let that infection spread like wildfire. And so you have to be very cautious with this. This is something that you're going to need to talk with your healthcare provider and, try to find out what their philosophy is, if they feel like they've gone down every single avenue possible to heal this infection. And the other thing is to ask for a second opinion. No matter what your situation is, you always have the right to a second opinion. Insurance will pay for that. It's always good when you're facing such a drastic decision to ask for a second opinion with somebody to actually look at the patient, look at the records. Sometimes they might have something different, maybe a specialist in a different area, area, part of town kind of thing, or maybe even in a different city if it's possible for you to travel. Maybe they can recommend somebody who specializes in something that, you might have to travel to go see that specialist. But it's always important to ask for that second opinion before making these huge decisions. I wish that I had an answer for you that I could say, oh, well, here is the magic answer. Unfortunately, I don't have that, and I really just wish that I did. Please let us know how this all turns out, because I'm hoping that in the blog or next month you'll write and say, well, we did see a person for a second opinion, and now we're going this other direction and completely. And that would be, and the amputation's off the table, and that would be wonderful. So I hope that all works out for you. And let us know how that goes. So sometimes you have to be pretty aggressive with people. Healthcare people should never be offended about a second opinion. That's just, most healthcare people stress and emphasize getting a second opinion because that just helps confirm what they were thinking, and it helps them grow if somebody else has something else. Most healthcare professionals really welcome that second opinion alternative. However, people are people, and some people don't ever like to be thought of as maybe they didn't make the right answer. So sometimes people are just busy being people and not thinking about the best thing that should be happening. Sometimes the egos get in the way, but a second opinion is the way to go there. Okay, so how to lessen urinary incontinence. Perfect question for merging in with urodynamic studies. If you have urodynamic studies done, you can see how the bladder and the sphincter is working together. So sometimes the bladder contracts and the sphincter stays open and the urine just pours out. That you have that urinary incontinence. There's some medication. If they diagnose that in the urodynamics, there's some medication that will help tighten the sphincter so that you will stop becoming incontinent, or it will greatly reduce. There are some other things that can happen, and that sometimes just the opposite happens, and the sphincter stays closed while the bladder's contracting, which backs that pressure up into your bladder. Sometimes people are not minding their oral intake of fluid, so they're drinking. Maybe they're sipping on a soda all day, which not only does the caffeine and the sugar in the soda, but the volume that they're drinking is causing incontinence. So you need to remember what goes in must come out, and so you need to balance that. Sometimes people only catheterize 2 times a day when maybe they need to be catheterizing every 4 to 6 hours. So there's a variety of things to do with that, but you can lessen your urinary incontinence, but you need to find out what's causing the urinary incontinence. So if it's a matter of over drinking or not catheterizing enough, that can quickly be remedied by changing your procedures and monitoring your fluid intake. Otherwise, you need to get that testing done so you can see what your problem is. Maybe it's not your cathing technique. It's not how much you're drinking. Maybe you're doing everything just right, but your sphincter is being naughty and not reacting as it should be reacting. Maybe the timing's off in your sphincter, or maybe the contraction of the bladder is too tight, and that can also be treated with medications or Botox injections to kind of calm the bladder. People become incontinent who don't have spinal cord injuries, and as I always say, you're not immune to these other little disease processes that go on, and so maybe something's happened elsewhere in your body system that's causing your bladder to have these violent contractions leading to incontinence. Sometimes women who've had children, or they've had particularly big children, sometimes there's a reaction in the bladder, some long-term effects where maybe years later, as they get older, they can't accommodate and hold their urine as well, and they become incontinent. You see a lot of advertisements on TV for different products, women who've had some leakage of urine for whatever reason. So hormonal changes is another thing, hormonal changes for women and for males. So there's all kinds of reasons why you could be incontinent, so you'll need to figure out what the source of that problem is. Now, Javier is sending his greetings from Mexico, so welcome, Javier. It's always nice to talk to people from other countries. We have quite a few listeners that are from different countries, so we'll add Javier to our list there. Are there any good books or resources on sex after spinal cord injury? Yes, there are lots and lots of books. You would be surprised. Again, you can Google sex after spinal cord injury, and some books will come up. You can look at Amazon. You can look at on there and also see different kinds of books will pop up on Google and Amazon. If you want to purchase a book on the subject, they will let you look at a chapter, so you'll kind of get a feel, is this kind of information that I want? They have little descriptors. People want different information. Some people are talking about sex and they're really talking about intimacy. Some people talk about sex and they're really talking about fostering a relationship. Some people are talking about the mechanics of the sexual response and how they can position themselves after spinal cord injury. These are all different kind of segues of the same topic. Some books contain all the information. Some are more specific to exactly what you're looking for. You can also call, again, the Paralysis Resource Center at the Christopher and Dana Reeve Paralysis Foundation, and they will have some books that they can refer to you. You can look up sex on the foundation website. There's a lot of website information. If you're looking for mechanics like how to achieve an erection, if you're a female and you want to know more about lubrication, there are all kinds of articles that are available right there on the Paralysis website, and you can go into the history of the blog. There's some that have been written there, so they're succinct and to the point, and this is what you need to do for these kinds of things. So that will be helpful. There's a lot of things out there, and a lot of it depends on exactly what you're seeking. Okay, so one more question about the spasticity. Somebody has spasticity in their whole body, especially in the hip to the ankle, and what can I do to lessen this? So that would be another, we talked about that earlier today, to follow treatment guidelines for spasticity, and doing some doing some range of motion, as well as taking some medication treatment. And with that, my voice is gone, so I will end it here. We're at the top of the hour. Thank you. Sorry.
Yeah, go get your drink of water. And I want to thank everybody for asking all the questions that you all did. And we have been putting in the chat box other resources and links to our website where you can get additional information. So this is being recorded and will be posted on our YouTube channel by the end of next week. And thank you all for joining us, and I hope you have a good rest of your day. Bye.